Namaskar and good day everyone. Welcome to the first international online conference on integrative pediatrics. I thank the organizers for giving me this opportunity to share today. My name is Malarvili Devi Krishnan. I am a certified yoga and meditation teacher from Hamsa House of Healing, Malaysia. My presentation for today is on yoga postures and breathing techniques for kids. My name is Malar. Due to lockdowns, or as referred here in Malaysia as MCO, or the Movement Control Order, the parents together with the children are now working and studying from home ever since the pandemic started more than a year ago. The children who used to engage themselves in outdoor activities are now forced to stay indoor with limited movement speeds. In order to keep them occupied, parents started letting the children to spend more time on the gadgets. And these children, when they start looking at the screens, they never stop. They get addicted to their only source of entertainment. Sitting or lying down on the couch for hours. And then at one point of time, they start becoming restless, trying to divert themselves or to just seek attention. They pick up fights with their other siblings or behave rudely to their parents or having total meltdowns, where they end up getting scolded or punished by the parents or the guardians. In the end, we have stressed out kids and stressed out parents or guardians, which results to a distressed family. Some of the brilliant ways to handle the situation are by getting the kids to practice yoga, breathing exercises, and doing some mindful activities. By not only occupying their time, these kids can utilize their energy into yoga postures, which makes them move their body and start gaining flexibility. These practices helps the kids to remain calm and to enjoy the present moment. These practices are also proven to decrease stress. Breathing techniques, which will be discussed in the next slides, helps to increase the lungs capacity and develops healthy lungs. Other than strengthening the children's attention span, these practices also sharpens the children's ability to focus and learn. Here I am sharing two fun-filled breathing techniques which can be taught to the children. The first one is balloon blowing. Blowing a balloon involves deep inhalation and exhalation. The force and strength of the lungs is tested in this activity, whereby it is not only a fun activity but also strengthens the lungs. Next is the feather blowing game, where the task is to keep the feather in the air. It is indeed a fun game to be played in a group. And at the same time, this game develops a pair of strong lungs too. Now, this is called the breath pod. There are 4 breathing exercises shown here, namely the 8 breathing, triangle breathing, square breathing, and star breathing. Parents can print out this page and let the children try out the breathing exercise. Next, let's look at the demonstration to use the breathe board. We will start off with the 8 breathing. So place the finger at the start point. From there, as you breathe in and you trace the circle, breathing in, and as you breathe out, continue tracing the other side of the 8. Inhale, breathing in and breathing out. One more round, breathing in and breathing out. Right, and you stop at the start point again. Next, let's look at the triangle breathing. So from the start point, we are going to breathe at each side for a count of 3 breaths. So from the start point, breathing in for 3, 1, 2, 3. Hold on for 3, 1, 2, 3. And breathe out for 3, 1, 2, 3. Continue breathing. Hold. And breathe out. One more round, breathe in. Hold. Breathe out. Right, now let's move on to the square breathing. From the start button, we will be breathing in for 4, holding for 4, breathing out for 4, and hold again for 4 in a circular motion. So the finger on the start point, and from here breathing in 1, 2, 3, 4. Hold 1, 2, 3, 4. Breathe out 1, 2, 3, 4. Hold 1, 2, 3, 4. Continue tracing. Breathe in. Hold. Breathe out. Hold. Done. Next, the last one is the interesting one called the star breathing, where from the start button at the side of the stars, okay, each side has it breathing in, holding at the point, and down, breathing out as it escalates down the line. So start button, and from the start point, breathing in, start, and hold. And from there, breathe out. And again, breathe in. Hold. Breathe out. Continue breathing as you breathe in. Out. And once done, you can conclude the session. Now, this breathe board is a very exciting tool that you can give for the children. So you can also laminate this piece of paper once printed out for it to be used for a longer time. Thank you. That is my presentation for today. Thank you for listening. Have a great day. Namaskar.
Thank you everyone for watching.
Yeah, we are back. I only love the butterfly pose. Dr. Aisha, she will start. Where is our poster presentation? She's there. Okay, I start the poster presentation from my laptop. Then I cannot call anybody. Can you see?
Primary care infants, child.
No. Can you see the presentation?
Infants, child
Dr.
follow-up.
No.
Okay. 1 second. Aisha, can you run Rukan's presentation from your laptop? Dr. Ahmed, good morning.
Good morning. How are you?
Wait. I start from my present laptop. Wait.
Good morning, Amina.
Wait, Aisha, I'm here. Dr. Ahmed, good morning.
Good morning. Good morning. How are you? Did you sleep well?
No, your friends did not allow me to sleep.
But you looks very nice.
What did I tell you, Dr. Aisha, last night? He will tell me, you look very nice, you don't sleep.
Yes, maybe it's better for you no sleeping, huh? That time you look very, very nice.
Wait. Dr. Aisha, what happened? You are not the co-host?
Alo.
1 minute.
Ya yok bu abicim, bu telefonda kendi kendine aramış yani. Hiç öylesine, tamam mı? Yani bir şey yok yani, tamam mı? Kusura bakma ya, tamam. Ben telefon son arananları, son seninle konuşmuşum. Sabahleyin baktım 2 sefer aramış. Allah Allah dedim lan. Tamam, tamam oldu bir şey.
Share screen and then you can put...
Sorry.
Oh, it's here. Yes. Aç. Okay. What?
Dr. Tahir from Malaysia is there. Where are you? Somewhere. Okay, now. I'm muting myself.
It's in my... Oh. Neredesin?
No. This one. Where is her presentation? Recorded presentation.
Okay. Hmm. It's here. Okay.
Aisha, it is not, the sound is very less, or what is happening?
Okay. I try to ameliorate.
Child health is shaped by the common effects of social.
Wait. Oh, the one, let me see how I have. I also have one, na? Let me see how I have. Dr. Dilek, your presentation is getting ready. La Habibi, wait, La Habibi, wait.
Primary care infants.
Oh, okay, Aisha, in my laptop, the presentation is coming on good. So I will play from my presentation, okay? 1 second. It is here.
Primary care. Primary care infant child follow-up in Turkey. I am Roken Özdemir. Bacılar Çakmak Family Health Center. Family Doctor Specialist.
You can hear her, right?
Child health is shaped by
Here
the
you can see.
effects of social
But you cannot
environment,
see.
Yeah.
physical environment.
One.
Child health is shaped by the common effects of social environment, physical environment, and monitoring purpose. Babies and children prevent and reduce illness, disability, these to support growth and development and to ensure a healthy life. Children's health follow-up principles. Protecting children's health, identifying risk situations and finding solutions. To inform families about child care, ensuring the implementation of the vaccination program. To ensure a healthy diet, to ensure healthy growth and development. Providing early diagnosis and treatment with screening. Identifying the family's problems and concerns about the child. Frequency of monitoring. Baby monitoring at birth, first week after birth, 50th day, 41st day, in second, third, fourth, sixth, ninth month. Child monitoring, a total of 5 follow-ups every 6 months between 12 to 36 months, 48 months, 60 months. School age and youth school. It should be done at least once a year between the ages of 6 and 21. Immunization, who are the primary care providers, are responsible for follow-ups except for the first follow-up, child follow-up, and all follow-ups between the ages of 6 and 19. Watching growth and development, measurements, head circumference. It is measured at every follow-up between the ages of 0 and 3. It is made from the most protein of age. It is measured in standing position. Weight measurement, it should be done at every follow-up, lying or sitting in infants. Larger ones should be measured in standing position. Body mass index, it should be measured after the 24th month. Blood pressure measurement, it is recommended to measure regularly once a year in children aged 3 years and above. Sensory screening, hearing evaluation, every newborn baby should definitely be referred for hearing screening. In our country, the National Newborn Hearing Screening Program was started in 2004. First 72 hours, hearing screening is recommended in the hospital without being discharged. Scan completion within 1 month. If there is a loss, diagnosis within 3 months. In the 6th month follow-up, it should be twice. The follow-up of this process is given to the family physician. Even if they have passed the hearing screening test, it is important to learn the observation of families about hearing, with age appropriate questions, and to increase their level of attention in well-child monitoring. In risky children, in addition to age-appropriate assessments, detailed audiological evaluations should be performed at the age of 2 or 2.5 years, and evaluations should be continued every 6 months until this age. Vision screening, the vision should be evaluated at the 15-day follow-up of the newborn and at every follow-up afterwards. Eye examination, red reflex test should be done. After 3 years of age, visual acuity examination should be done with LEA symbols. In the first 3 years of age, if there is any pathological finding in the examination and there is a risk factor, it should be directed to the ophthalmologist. Risk factors, family history, rubella in early pregnancy, severe prematurity, ophthalmia neonatal, newborns with sensory hearing loss, dysmorphic syndromes, those with developmental delay. Although there is no risk factor, it should be directed to the ophthalmologist at the age of 3, 4, 6, 8, 10, 12, 15, 18. Developmental evaluations, physical development. At each visit, the gross fine motor, language, personal, social skills appropriate for the children's age should be questioned, observed, and if any the determination of the families should be evaluated. Social development, 6 weeks social smile, 8 weeks starts making noises. Absence of a smile in the 3rd month is pathological. 12th week, observers, people, and objects around. For 8 months, return to voice. In the 6th month, when her mother to take her in her arms, she opens her arms. Not returning to his name when he was 10 months old. It is pathological that he doesn't point to the object that attracts his attention at the age of 2 years. Autism assessment. Every child on the 18th and 24th month. It should be evaluated at the age of 3 months and 3 years. M-check test is performed for evaluations. Attention deficit and hyperactivity or evaluated once between 48-60 months. Scans, neonatal metabolic screening, phenylketonuria, hypothyroidism, biotidinas, and cystic fibrosis are screened with heat prick. If the first was taken before 48 hours, a second heel prick symbol should be taken. Screening for hyperlipidemia. An annual risk assessment should be performed in all children after the age of 2, and cholesterol and lipid levels should be checked for those with risk factors. Risk factors: presence of obesity, hypertension, diabetes in the child, cholesterol in mother or father higher than 240 milligram deciliter, coronary artery disease or stroke in the family before the age of 55. Lipoprotein analysis should be performed if total cholesterol is higher than 200 milligram deciliter in children in the risk group. If LDL is less than 110 milligram deciliter, examination every 5 years. LDL between 110 and 129 once a year. If LDL is higher than 130 milligram deciliter, and diet program and follow-up is recommended. Developmental hip dysplasia screening. The family should be informed in the first 48 hours. Risk assessment and physical examination should be performed on the 31st day. Risky cases should be directed to the relevant branch. Screening by the family doctor is mandatory. Screening for urinary infection. For the detection of urinary tract infection, one of the main causes of chronic kidney failure. 1-year-old, 5-year-old, it is
randevu alacak. Başka yapacağımız bir şey yok.
In the neonatal period, hydrocephalus, cleft palatal lip, congenital heart disease, undescended testicle, hypospadias, a physical examination should be performed for the hernia. Immunization. Within the scope of the expanded immunization program, vaccination should be made in accordance with the National Infancy and Childhood Vaccination Schedule. Immunization is carried out against invasive diseases due to whooping, cough, diphtheria, tetanus, measles, rubella, mumps, tuberculosis, poliomyelitis, hepatitis B, hepatitis A, chickenpox, Haemophilus influenza type B, Streptococcus pneumoniae. Turkish Public Ministry of Health, our national vaccination scheme. Iron and vitamin D prophylaxis. In accordance with infant and child follow-up protocol. Iron prophylaxis is applied to babies between the ages of 4 to 12 months. When they are 9 months old, their hemoglobin values should be checked. 12 to 24 months, palmar examination should be done. Hemoglobin is tested once at the age of 5, early, middle, and late adolescence. Vitamin D prophylaxis is applied to all babies from birth to 1 year old. Information about breast milk and breastfeeding. In all pregnancy follow-ups starting from the 32nd week of pregnancy. All babies from newborn to 2 years old are in follow-up. Information on breast milk and breastfeeding is provided. Unstandard testicle examination. It must be done at least once between 6 months and 1 year old. Healthy diet counseling. 0, 1 year old baby, 1, 5 years old preschool. During the school year between the age of 6 and 18. Information is given at least once every semester about a healthy diet. Obesity screening. Weight, height, body mass index are measured once a year in order to prevent obesity during the school trade between the ages of 18. Information about tobacco and addictive substance. All families with children under the age of 18 are informed about the protection of their children from tobacco and addictive substances at least once a year, and awareness is raised. Questioning child neglect and child maltreatment. 0, 6 years old children at every examination. Questioning, observation, and examination should be done once a year in children aged between 7 and 18. In Turkey, primary care examination and follow-ups, vaccines under the immunization program, iron support, diabetes support, periodic examination, leukocyte, urine and blood tests are done free of charge. Healthy child, healthy generation, healthy and happy family. Thank you.
Dr. Good, now you can have your good morning. We have 15 minutes for the introduction.
I think you should have the good morning, no? Everyone should have a good morning. I wish I could give everyone also a cup of coffee.
Where? I'll have to go and bring. So now you can unmute all, and then we can, I'll start calling up for the panel discussion, and we have the
everyone can unmute themselves, no problem.
Yeah. So now you can say good morning.
You start, Professor Ather.
No, you start.
You're,
I have to call the panelists.
you're Professor Amina Pharmaceutical. I think you should greet everyone. Oh, Dr. Ahmed, right?
Dr. Ahmed will be here. I call him.
Tamam. O kapatmış. Tamam.
We have 15 minutes to start the conference, so we have.
Good morning.
Good morning Ayşe. Good morning. Selamun aleyküm.
Alaikum salam.
Dr. Ahmed, we say for 15 minutes, good morning to all. So we wait till 8 o'clock. I'm calling for
Okay.
the panel discussion. I call everybody, come.
Before the opening speech, our panel, or after my opening speech?
After your opening speech.
Okay.
So we wait. Now we unmute. We ask everybody to unmute and say good morning.
Okay. Hello. Alo. Aynur'cum
Dr. Ahmed also works from the office. See, he can get the coffee from there. Dr. Tahir, Dr. Ahmed is sitting in the office. He's the head of the hospital. Just think if it is head of the hospital in India. He's laughing. Dr. Guri, he is the one who gave me the idea to change the Zoom link. I was very, very nice. I sent to everyone. And I told Dr. Gur, upgrade. Dr. Tahir gave an experience yesterday. You know what he said? He said, they announced a seminar like this and they shared the Zoom link and then I think Dr. Tahir, it's better you give us the experience of your thing. Just share. He's smiling.
Yeah, actually what happened, we had a conference with a limited capacity of 100. Since Zoom allowed only 100 at the time we did. So we just shared the link for Zoom to the registered participant, and it happened when we started the conference, and a lot of unregistered people were there. So we don't know exactly what happens. So we, because I'm not from IT, so we asked the IT guy. IT guy was also baffled exactly what is happening because this was happening for the first time. Because most of the conference we do actually physical. And then we realized, oh, there are a lot of people who actually should not be in, but we were, of no idea exactly how they entered. But when I was discussing with Dr. Amina yesterday, then she said people will share the link once you share with them. And this actually happened. Then yesterday only I realized, oh, this also has happened with us actually before. So, yeah.
Dr. Gur, he said that it started coming in such a way, the actual speaker couldn't join. It was full.
Yeah.
So Dr. Gur and me decided to change the Zoom link. We decided to change the Zoom link and we made a new Zoom link yesterday and we sent it across. Dr. Tahir, we can have 500,000, 10,000, but we want a very limited one. You see, we don't have an informal introduction. We don't have pharmacology. Dr. Dilek knows I'm behaving more like German. No pharma industry here. No hello. No, in India, how they do for the conference, welcome. Then you have Garland. Then you have this. I was like, I think Dr. Bhumesh will be saying what kind of a conference these people are sitting and chatting here. In India, you have to read the CV of the speaker. Here we don't read, we just go bump in. And that it is very difficult to handle with countries like India. Pakistan, Idris is there. Idris, you got the new message? Idris, where are you? Hello? Hello. We make unmute to all, but everybody is asked all to unmute. Okay, 1 second. We have made. What happened?
Professor Ather, when is my session? When is my talk?
Can you just check your schedule on the website? Just click on the website and check. Dr. Sunil, it is there on the website now. What time?
Yeah, everything is there.
Yeah,
Dr. Sunil, good morning. How are you?
Good morning. I'm fine.
Doing
How are you,
well?
Dr.
No, he goes on and off, so we cannot see it.
Sunil, good morning.
Anyway, Dr. Sunil, morning, half an hour. Dr. Dilek, half an hour we had a session how to start the Zoom because we couldn't make co-host, we couldn't mute, we couldn't chat. So we took a class today morning on Zoom for Zoom.
Yeah, Professor Amina, I think we can start the introduction, no? And then to start with the lecture.
Of course, yes, we can. We have 10 minutes. I'm waiting for the panelists to join.
Oh.
So once the panelists are here, then we can have the panel discussion and then we'll have Dr. Anthony. Dr. Ahmed is with us.
I'm trying to add the,
Dr. Ahmed here.
Yes, Dr. Ahmed there. He is there live.
Şimdi
No,
You want to play his introduction?
yes, I played.
Sunil, can you put that schedule? Okay.
It's just click on the link, Dr. Bhumesh. Can you just click on the link on the website? It's there. Just scroll down there. Because all my phones are busy. My laptop is busy. My phone is busy. I cannot touch anything.
www.aahn.eu.
Yeah, the same place where you registered.
I am
Yeah.
okay. I play it. Okay.
Yes. You can play. Dr. Ahmad, you are live, but we still listen to your recording. What do you do with the sound, Dr. Aisha?
Okay. I try to ameliorate.
And we are like to the increasing number of attendants and the growing interest from the scientific enhancement. We are also happy to observe the increasing level of science at the presentation. Today, our topic is integrative approach to pediatric patient population. I wish you a successful meeting. Have a nice meeting also.
Just here, how I quite it. Oh, no. Where is...
Yeah, he's there live, so he can talk to us live. Don't worry.
Okay.
Yes.
Aisha, can you stop the share screen?
Very sorry, Amina.
No, Aisha. Dr. Ahmad is there, so he can talk directly.
Okay, I am ready because in the morning I have a visit the bladder cancer patient, so now I am all right. I can join you.
No problem. Hello, Jafar. Ask to unmute.
Hi, good morning. How are you?
Morning. Look, Doctor, we are all there. We are waiting. Where is our Ashraf bhai? Where is our Ashwin? Dr. Sunil, you don't go vanish. Unmute the video. Then I'll have to search.
Neil, unmute yourself.
You have to unmute yourself.
No, it's not working. That's okay. Now it's working.
What? Now it's working. Everybody you can unmute. No problem there. You can unmute.
So you want me to unmute? Hi.
Yeah, because we will start a quick panel discussion here. I'm only looking at my boss, Vincenzo. He wants to be there. He's calling up somebody. Let me see. Dr. Ahmed, you can do the introduction. No, it's 8 o'clock. It is still 7:54. So we can have the introduction till we have other panelists to join. So Dr. Jafar is from the state of Karnataka. And he is, Dr. Jafar, better I don't even call you Dr. Jafar. I call you Jafar. Sorry, boss. You know, he is in such a high position. I barge into his office. I said, where are you? And everybody will be looking, who is she? So he was a commissioner of education for the whole state in India, for the whole of Karnataka state. So we have been discussing immensely about the third wave, whether it will affect the children and others. So that's why we have him there as a panelist. And then we have Dr. Rajesh there, and I'm calling the others. Because we said the panel discussion at 8, now it is 7:55. We have 5 minutes, so we can introduce each others and we can have an informal discussion. Dr. Can you please please, Dr. Idris, can you please call Dr. Shahzad? Yes, yes, Jafar, it's better you introduce yourself. We have Dr. Ahmed there. I asked him to share his experience regarding handling of COVID cases with children. Dr. Ahmed, Dr. Jafar, and Mr. Ashraful Hassan, they both are on the ground, and you see the situation in India is going out of the hands. Unfortunately, I don't want to say anything. I'm just trying to control myself. So everybody has a question. The third wave, will it be for children? How to handle? That's why I squeezed my presentation. Dr. Gur was a bit unhappy that I deleted my presentation and I put the panel discussion in the conference. Aisha, Mafirat, Gur, all the others were unhappy that I removed my presentation, but this panel discussion was very, very important for us. The 30-minute discussion, like how Dr. Dilek knows in Germany, how safely we handle the children. So Dr. Dilek, because the children in Germany, so we have Dr. Dilek from Germany, then we have Dr. Ahmed from Turkey, we have all the many other Turkish doctors, and we have Dr. Raji, Dr. Bhumesh from India, Dr. Sunil from India, and Jafar, of course, you are a policy maker. That's why I'm pulling you here. I'm also asking Ashwin to join. Dr. Sunil, could you reach Ashwin there?
Actually, I've sent him I called him. He did not pick up the phone. I've sent him the message. He'll join in. He'll join in very in a few minutes.
Yes.
Even Dr.
So
Vijay is going to join in.
Ashwin is one of the person who is policy maker. He is one of the advisors for policy making with the Indian government. And then we have Dr. Tahir, who is an Indian but residing in Malaysia, but his heart beats for India. So I have dragged him also here. And Dr. Sunil, Dr. Vijay. Okay.
5 minutes. He's joining in 5 minutes.
Okay, so 8 o'clock means 8 o'clock. Dilek, we both are Germans. We are always there before time. Dilek is from Turkish. So Aisha, you can speak to her in Turkish. She can speak Turkish better than English and Deutsch. So she has been immense support, and she has worked. I mean, she has worked extensively. I think we should be very proud to say she is one of the leading. What can I say? She's one of the leading expert, and always she's worried about people. Always worried about research. I don't know how to give an extensive, what can I say? I can read her CV, I can read her thing. But apart from that, most of the experts, yes, they have a huge, long CV, but they also need to have a heart and the soul for the system or to help the people. So this is the person who is right there. And I know Jafar was the first one who said, okay, come, let us have this panel discussion. Let us have it immediately. So Jafar, yes, we have time till another 5 minutes. I'm stealing your time from your office. I know it's really, Ashwin is joining. So Jafar is seeing me after how many years?
I think 4 years.
4 years.
4 years.
Yeah, he's seeing me after 4 years. So many people ask me, where did I vanish? So now when they see me, they ask, what did you do? Did you go and get transformation? Yeah, Jafar. So we have Dr. Salahuddin also from the ground level there. And of course, Jafar, how can I forget my brother Amin? I have asked him also to join. Yeah. Yes, Jafar, do you have anything?
Good morning, everybody. I'll just give a quick introduction. In India, we have a system of selecting an Indian administrative service where the officers selected at service are posted at the central as well as at the state level governments on policy and execution level. So I have worked in rural development department for 4 years, education department for 4 years, and was in the district level, that is the local level governance for about 5 years. And currently for the last 2 years, I am handling the finance department of the state. Coming to the COVID situation, Bangalore has been seeing its very deadly second wave. But hopefully in Bangalore, which is the capital city, we have seen the peak and the cases are going down. we have seen up to 25,000 cases a day, but currently we are stabilizing around 10 to 11,000 cases a day. But the danger, Bangalore being the biggest cities, we could handle to some extent. But the cause of worry in Karnataka as well as in India is that the infection is moving towards countryside in the villages where systems will not be as robust as it is there in the cities. So that's an issue. And unlike the previous months, now we have been testing quite high. Of course, now there are certain allegations that the testing numbers are coming down. Still, test positivity rate is a concern. It is around 20-25% in Karnataka. In Bangalore, test positivity rate, Bangalore results, it's coming down. So what they did is, in government, when things were going out of hands in the first wave in July 2020, Bangalore government divided the Bangalore city into 8 zones. This city is divided into 8 zones, and one senior minister and one senior officer was given charge of each of the zone. So for the last more than a year, I have been looking after one small zone in Bangalore. So have been part of the team there. Basically, we used to do test, trace, and handle the clinical part. But the stark difference with first wave and second wave, between first wave and second wave, what we are seeing is, because of the sheer number of cases that has gone up to 5 times than the first wave, all senior officers are also now more involved in the clinical management, hunting for beds, looking at ICU beds, ventilators, and this kind of involvement in clinical management by the policymakers have definitely taken its toll on the public health issues like tracing, contact tracing, and containment watch. So that's quickly, I thought I'll brief about the situation, what we are facing today. But at the same time, we have been doing a lot of tests. Now, government is insisting that the maximum number of tests should be on RT-PCR, but now for the last few days, we are looking at antigen test also. Since a lot of symptomatic patients are there, we are using antigen test, which will give quick result. And we have been pushing our labs to give the results in 24 hours so that the result is out fast, detection is fast, and the containment can be done fast. And finally, a large number of patients we are putting on home isolation, because though there are cases where we see things are going out of control, we're putting on home isolation. And one last word is, last 2 weeks, we are seeing very young population getting very serious and getting onto the ICU and ventilator. We're seeing people in 20s and 30s, their condition deteriorating and going into ventilators. This development we are seeing for the last 2 weeks. Thank you.
Yes, thank you, Jafar. Amin also has joined. Amin, can you unmute? Ashwin also has joined. Ashwin, can you unmute?
Yes, Dr. Ather.
Yeah, Ashwin is also here. Ashwin, a quick, brief introduction. Dr. Ahmed is also there. So we're just having a little bit of brief introduction before we start the panel discussion. So this is Ashwin. Ashwin, it's better you introduce yourself because I'm very bad in this.
Yeah. So hello, everyone. So I am basically the CEO of a company called Sapio Analytics, which is a government advisory firm. We work with the government of India and various state governments in India, including government of Telangana, government of UP, primarily working towards using technology to help them take the right decisions, make the right policies. So of course, with the whole COVID situation, we have been very actively involved on a number of committees trying to solve the situation in India. In the last year, during the first wave, we were majorly focused on the decision support systems. For example, the entire concept of granular lockdown and containment zones to a great extent was created by us and then adopted by the government of India as well. This second wave came across as a much bigger challenge beyond all of that what we had faced in the last year, because the major challenges were from the angle of availability of resources. So then government, with the support of government of India, we created this initiative called Sutra, which is basically trying to connect citizens to each other to solve the problem of availability of resources. But as we all know, the problem still persists to a great extent. We have also been seeing lots of data because we also have this protocol bot for doctors. So, the guidelines which are created by ICMR and then created by various healthcare institutions that are associated with us. Based on that, we have created this protocol bot which a doctor can go through and know what they should be taking as an action depending on various cases which are available to them. And data which comes from that shows, as Dr. Jafar also told, is that a large population is the very young population now. In the last 2 weeks, especially, we have seen more than 70% of the cases which are coming to these doctors who are associated with our protocol bot are less than the age of 40, and a number of them are also minors. So yeah, so that is clearly a much more alarming situation than what was the case 1 year ago, and we need to kind of work towards that. We're seeing we'll need to come together to figure out what can be done.
Thanks, Ashwin. Amin, you're there. So I've asked even Amin to join, Dr. Yasser. So I tried to request the experts like Dr. Ahmed is heading the hospitals in Istanbul, the Turkish experience. Jafar, that would be a very good experience and take home message, because alhamdulillah, they have excellently managed in Turkey. Of course, children are children. And also in Germany, Dr. Dilek is here from Germany, and I've requested Professor Naimi to join from Iran, and Dr. Tahir is from Malaysia.
Also,
Vincenzo will join us.
Dr. Shahzad is with us from Pakistan. He just joined us.
He is going to join us.
He's
again.
with us, yeah.
Yeah. So he's with us.
Yeah. Dr. Shahzad, you with us?
Yeah, Dr. Shahzad is from Pakistan. So it is like, this is an amazing panel discussion right now with the heated thing. Dr. Gur is from Israel. Dr. Shahbaz is from Pakistan. Dr. Naimi is from Iran. We have Indians, we have Turkish, we have Germans, we have Belgium. I don't know. I miss the Americans. They are sleeping.
Amina, if you want, I can start my presentation. Yes. Okay. Good morning for everybody. This is the 5th hour conference series. As a health science university, we are very happy to support this nice meetings series. Now I will mention about the third waves in COVID-19. What about in children in Turkey? Maybe you know, but I am also chief doctor of the very big research and training hospital in Istanbul. We have 600 beds, and then 120 children beds, and then intensive care unit, newborn and children intensive care units. And this third wave of COVID-19 virus infection, which started in the March of this year in Turkey, nearly 1 year before it starts, but after 1 year, the third wave starts in March and has affected the pediatric patients more than the first and second wave. During this time, the number of patients that we followed as an inpatient in our clinic has increased. Really, it's very increased numbers. These patients mostly came to our hospital high fever, as well as clinical fatigue and pneumonia. And then their CT scans most showed typically ground glass opacity and had longer recovery periods. So those with pneumonia clinic, we treated the non-specific antibiotics, and also favipiravir was added the treatment regime of this with severe symptoms and were between 16 and 17 years old. This is very important. This range is 16 and 17 years old. Patients with other underlying chronic illness were followed in the pediatric intensive care unit. We had 0 mortality, thanks to God, Allah shukr. And then this British mutation was found in our hospital only 2 patients. one of whom had a chronic illness, therefore was followed in the pediatric intensive care unit. The other patient was a 16 years old with mild respiratory difficulties with pneumonia clinical with Leicester longer. Overall, during the third wave of COVID-19 infection, there was an increase of 20 and 30% of pediatric patients. We didn't see like this in the first and second wave, but the third one also affected from the mutations, 20 or 30% of more increasing in pediatric patients. Meanwhile, the number of patients who didn't have the clinical symptoms of COVID-19 but had family contact history and therefore gave COVID-19 PCR sample and was found positive, increased drastically. And then also in Turkey, there are no studies about COVID-19 vaccine in pediatric patients. We have many studies in the adult patients. And according to United States Center of Disease Control and Prevention reports, there are studies being conducted the vaccination in patients 12 to 16 years old. Now, I am a urologist, and also in the last 5 years, I am interested the chief of the traditional complementary medicine section. So I can only say about the pediatric population. This is the view of from Turkey. Thank you.
Thank you, Dr. Ahmed. See, Ashwin, when he said 120 pediatric ICU units, and he said zero mortality.
Yes.
You know, this counts. Jafar, did you hear why I pulled you to Dr. Ahmed? Because it is a public hospital. It's not a private hospital. And there is zero mortality. And this is one of the amazing things, like what we see when they're saying about it. For example, when you have, like he said, 12 to 16 years, we have the what can we say? We are starting to vaccinate, or there is research of vaccines. But what about below 12? What about the preteen? That is what Jafar and me are saying, 10, 11, 12. What about the preteen? They're in between, they're crumpled. They don't know whether they are kids, they don't know whether they're adults. Now you have the infection coming. So Professor Kadirjan is there. Yesterday we had a recording. Professor Kadirjan, can you just unmute? He's also from Turkey. And then as we were discussing, we were recording his presentation. I said, what could be the first sign, even without the real-time PCR, even without that? He said, the immediate sign of any viral infection are the eyes. Immediate. So we had the eyes diagnosis, we had the tongue diagnosis. Immediately, he said, the first sign, whether there is fever, any kind of fever, any kind of infection, the eyes are the window to the body. So Professor Kadirjan said the eyes, careful examination of the child. The child is rubbing the eyes or something. That itself will give us the first information for any kind of infection. Yeah. So I think Professor Kadirjan, can you just share your views, like how can we help by having a slight diagnosis of the eyes? Is it possible that we can correlate it for the third wave as a predictive diagnosis?
In ophthalmology, the appearance of the eye is very important for detecting some diseases. Really, as for the pandemics, the ophthalmological examination is the first leaving of the entrance of any infection to the body. And this is another entrance for the disease. Okay, but in the conjunctival solutions and excretions, there are some antidotes and antiseptic excretions of the eye solution. These solutions can kill the virus, but each in the eyes getting the dirty hands to the eyes is a very important issue for this infection or the other infections. So the eye examination is a very important issue for these pandemics examinations, but by means of the lysozyme enzyme in the eye solution, especially the conjunctival excretion, can kill the small amounts of the virus. So the ophthalmologic and the eye entrance for the infection is an open door for the infection. It's okay, but because of the defensive solutions in the conjunctival excretions is a defense mechanism for the body. But avoiding to rub the eyes, avoiding to get the dirty hands or clean hands to the eye is an important issue. So we use, especially in the intensive care units, to wear glasses is a very important issue against the spreading the virus. But thanks God, because of the lysozyme enzyme and the other antiseptic excretions of the conjunctival excretions, the virus cannot enter so widely from the eye door.
Yeah,
I hope I could tell my
yes.
these are my considerations and my fear about the virus.
Yeah, because as I was talking with some of the pediatricians here and some of the parents here in Germany, we are having the mask till here. When we close, we are closing our mask till here. Yeah.
Yes.
We are closing the mask till here, but even the eyes are the window for the infection. So that means, does that mean we close the whole face? Was a question everybody were asking. But for the children, they can rub the nose, they can rub the eyes. But for the children, they more than rubbing the nose, they try to rub the eyes. Just imagine, as children, we try to pull like this and like this. We cannot put the mask.
Yes.
So now, only one thing, what was suggested here in Germany, like when I spoke to a couple of the parents and the teachers, they said washing of the face, washing of the eyes itself is enough. You know, washing of the eyes and washing of the face for the children. Just when you see the children having a high temperature here, washing of the face is being advised here for fever. At least wash the face, wash the eyes and the face. So even a simple diagnosis, because it takes time to go for a real-time PCR, it takes time for this, but till then we cannot keep on waiting. We cannot keep on waiting. But when you look into the eyes, for example, the fundus around, it's congested. There are the different shapes. The appearance of the fundus of the eye itself will give which infection it is. So Professor Kadirjan was sharing, like when he looks into the eye, he can easily make out whether it is a long-term infection, whether it's a chronic infection, whether it's an acute infection, whether it is by trauma or whether it is by foreign body or whether it is by viral infection. So Dr. Gur, you said about this examination of the eye and examination of the tongue, something like that. So is it possible, Dr. Gur, like we have just looking at the tongue, we can say, okay, this child needs something like this? That would be his expertise. Yes, Dr. Gur.
I think that it can be a general sign. It cannot be a differential diagnosis for anything.
No, general sign for any kid. For example, looking at the tongue for some, the dryness of the tongue is dehydrated, right? Simple tips.
Yeah, complexion, immediate complexion of the face, out of the ordinary color of the child is very easy. Behavior of sudden fatigue, brightness of the eyes, over redness of the tongue, sometimes red papilla on the tongue. And for smaller kids, we use the index finger often to rub and to see the vein. If the vein is start to be more purplish or longer, also can indicate some kind of immune disturbance for the kid. That's in general, but I think mostly every parent can identify in his child the special behavior that's showing this kind of signs. But it's relatively easy to see when they develop. But when they develop, usually they develop it very fast. At least here, what we're seeing now is the symptoms among kids about the long COVID, that many kids that had suffered from the COVID infection and had recovered from light disease, after several months, we see them in the clinic with extreme fatigue, muscle pains, headaches, some symptoms of autoimmune condition like joint pain, after abnormal liver function. For some kids, we even saw under the age of 18 in ultrasound fatty liver that have been developed, light fatty liver after the corona infection. And only few cases have been vaccinated under the age of 16, as they were defined for high-risk cases. Other than that, it's the same condition, people waiting for the approval of the vaccination.
Dr. Good, like for example, the children who have recovered from COVID, now, you know, like prevention, what would you suggest for prevention?
Basically, the first thing is
the simple ones, like take-home messages, like like Mr. Jaffer, Ashwin, all of them are their policies, because we can make a document, a simple document where we can say what could be the take-home message.
I think when Malad actually introduced in the morning the problem of kids staying at home, this is the base. When the kids going out of their natural rhythm, because they are very movable creatures, they don't good for them to stay stand. So keep the kids moving, keep them exercise. They have natural ability of high immune, unless there are kids in risk, and this is something else. Let them sleep earlier, because when they stay home, they stay with the screens, they go to sleep late. They go to sleep late, their temperament become cold, they get more infected. Keep them on the right diet. I think the best thing is to keep the kids with very good immune system, the very basics one, because you cannot start giving everyone herbs everywhere. It's impossible. And for kids,
India is a paradise of herbs and vegetables, so don't worry, there's enough of herbs and vegetables in India.
So for that thing, I think it's absolutely to add to the food of the kids in natural, more fresh seasoning like thyme, basil, that can increase the immunity for viral infection, and to use more aromatic herbs that can be given as tea or mixed with other things like Salvia officinalis, oregano. We often use here the oregano oil. I mean, all kinds of oregano have a very high potential of killing viruses, and very simple infusion of buying oregano in the market or planted in the pot can be easily be infused in oil. Usually we use olive oil on the sum of 50 grams per even something like half a liter of an oil. Put it on the window to get some light, and the kids can be infused or to the nose or under the tongue. Few drops per day can be highly effective for every start of infection that only starts. And usually as the kids become very sick, they become, with the right diagnosis, better, fast. And I think the main problem is to keep them moving, which is a big challenge when it's under quarantine or you try to keep them in the house. But basically, I think these are the main thing. For some, we recommend to do moxibation and to keep warm some of the acupoints on the body, and that can tonify the immune system, like stomach 36 or colon 4. Even just to massage the point can stimulate the immune system. Kids are responding very well for acupressure, and it's very easy to guide the parents to do it as well. That's the basics.
You are the most luckiest person who sits in between the environment. You can hear the hens, cocks from his background. He has animals, he has goats. Yeah.
I think we have.
Right now he's in Ashdod, and suddenly he calls me and says something is happening.
I think we have Dr. Shehzad. I follow his post every day that he report in Islamabad. What is the condition? I think he can shed some light. What is the policy?
Has he joined, Dr. Gur?
Yeah. He texted me. Dr. Shehzad, you with us? Can you unmute yourself?
Can you please unmute yourself? So, Dr. Gur, you also seen the third wave in Israel. We have children.
Yeah, I can hear you, Gur, and Amina. How are you?
Welcome.
Yeah, Dr. Shehzad, can you unmute your video? So we have.
Yeah, sure.
Every
Can
day
you see me
he's
now?
posting there. You know, Ashwin, what he does, he's like a bulletin. You want to see the news from Pakistan, you can just see. Being the dean of health sciences of Karachi is active on Facebook. There, and he calls me 1:30 in the night. He calls me and said, "I just finished the presentation." I said, 1:30, it's German or Pakistan time, and he 24/7.
Yeah, actually, we need this.
One second. Let me mute. Okay. Yes, Dr. Shehzad.
Thank you very much. And it's really great to have a connection with you guys and the great work you are doing. I actually sent my presentation. I hope you have seen that. There was a recorded presentation.
Now we're just having, just a second. Now we're just having a panel discussion because India and Pakistan are so different. India and Pakistan are absolutely no different. We have the same Ghana. What we say Ghana is food, Pina is the drinks, and Ghana drinks is not the drinks of others. We have our own yogurt. Iran also we have in Pakistan and India, and Ghana is the same Bollywood and songs and other things.
Yeah, exactly. You are right. So what we have done is in COVID, there was a big issue in the first wave when we had a lot of cases, but most of the time in the first wave, it was the elderly which were affected. So we touched the figure of around 6,000, 7,000 per day in the first wave, which actually started on the 26th of February last year. So the first case in Pakistan was in 26 February 2020. Later on, it kept on increasing gradually. So February, March were pretty stable, but it started increasing in April, May, and June. It touched the peak in June, July, and we touched the cases of around 7,000, 6,500, 6,000 per day. The deaths were also 150 per day. The investigation and the testing capacity was less. We were only doing 20,000, 30,000 tests, but later on increased. We had a second wave in winters. So second wave was also short-lived. It didn't go much scarier. It almost stopped in January 2021. And then we thought we are stable, so we opened up a lot of things. So we opened education institutions, we opened universities, thinking that, and you know, nobody is expert in COVID. If you say in this world, even Fauci is struggling with a lot of things he said, and now again there are many things which are going on internationally. You cannot predict this virus, and the way it has taken us, it actually has created a lot of holes in the public health epidemiology and public health understanding. In the third wave, it suddenly started picking up. It wasn't at that time, it wasn't the incidence of India that you have that the Kumbh Mela. So before Kumbh Mela, we had a spike. The cases were more than India per day. The deaths were higher. And then suddenly, and nobody was taking care in Pakistan. You know, no one was afraid of the third wave. They said it's only two waves which can occur. There will not be any third wave. So everybody was casual. The universities were open. We opened the classes, face-to-face interviews, meetings. I started traveling Karachi, Lahore, Islamabad, physical meetings, no SOPs, nothing. We thought it is over and the vaccination is here. So I got vaccinated, others got vaccinated as well. Then suddenly the news started coming from India. And we were told that the cases are 300,000, 350,000, and 4,000 deaths per day. Everybody became fearful. The ministry and everybody, they started having a lot of discussion. So we closed a lot of things again. It peaked up to the, we have a Eid every year. This festivity, it is also, Turkey is also having this activity. In all the Muslim countries, we celebrate this Eid al-Fitr. So in the Eid days, we had a lot of crowds and the cases were increased. Now, because the Eid surge has gone down, so now we are having around, say, 3,000 cases per day, around 150 to 100 deaths per day. And we are having a positivity, test positivity of around, say, 6% to 9%, varying between 6% to 9%. Today is 6%. So we hope that it is going down. When talking about children, the first wave had very little effect on children in Pakistan. So there were not much children. We although tested some of the children as well, it was negative. So many of the children, even their parents were positive. The children didn't get any symptom. In second wave also, the children were not significant number. But in third wave, a huge number of children got infected. For the last 3-4 months, we have witnessed a huge number of children. So if total, you can say, if total new cases were 100,000, 6,000 to 7,000 were children, which was not the case in the first and second wave. I don't know what happened. Maybe the virulence or the infectivity of the virus has something to do, or the immunity of the children. But in the third wave, children were more, and among the dead also, there were some fatalities also in the children cases. So we have fatality from less than 1, less than 20, less than 30, gradually increasing. The more fatality, the highest fatality in Pakistan is, the more fatal age groups are between 50 to 60, and then second highest is 60 to 70, and then it decreases again because the number is less in the elderly. We have very life expectancy of not more than 65, 66 years. So Amina, over to you.
Thank you, Dr. Shahzad. See, Ashwin, that is what was alarming me. The third wave, he says again to the children, why nobody has a question? And he is a graduate from UK, and that is how he compares. So what we said is, he suddenly says one line, Desi to Desi hai, whether Indians or Pakistan, like now we are getting the third wave. Now what is with the third wave is my question. Dr. Sunil, what do you say? You're right there in the middle in Bangalore.
Okay. Thank you for getting me into the conference. The most important thing, as I was hearing everybody, that the third wave is going to hit the children and all those things. And there is a particular pattern which we saw during the first wave and the second wave. The first wave, as rightly pointed out, it hit most of the elderly population. The second wave is, between, we are seeing the younger age group from 25 to 40, as Ashwin and Dr. Jaffer rightly pointed out, it hit the 25-40 years of age. And some few children's. Now there are few reports and reported articles which are published in CDC as well as this thing, why these children are not affected as much as the adults. This is what is the because they say that the ACE receptors in children are much less compared to the adults, and the spike protein of the virus is much more attachable to the AC receptor when it enters the cell. So what they are saying is the children has got less number of AC receptors. That is why the viral replication in the children is much less. And that is why the complication in the children are much less. That is the what is been reported in many of the journals which I have gone through. But saying that this virus is really tricky. Very frank with Dr. Ashwin, Dr. Jaffer, Dr. Gur, and the other experts who had already spoken. This virus is very tricky. It has mutated, and instead of we being ahead of the virus and preventing the viral spread, The virus is ahead of us and we are running behind the virus. This is what is basically happening. We are trying to tweak the vaccines. We are trying to do all kinds of stuff, and the virus is mutating, and there are a lot of mutations which has already happened. And they, I mean, to the dismay of the many, I mean, virologists, the mutations are happening, I mean, continuously, which is a known case in case of RNA virus. RNA virus mutates very fast. This is known fact. And this mutation is really affecting the, we don't know. There are not much studies which are come out to say that the mutation has affected the vaccinated population. So we don't have any kind of such kind of a data. Still, the data now, whatever we have, we know that the vaccines are still active on the mutated virus, and the antibodies are still the neutralizing antibodies which are produced after vaccination are still preventing the infection in the vaccinated population, even if there is a single dose vaccination. So that's a good policy which we have seen in case of UK and I mean US and other population. Even a single dose of vaccine is really effective in preventing serious infections. I'm not talking about mild infections. I'm talking about a serious infection. Now, the whole question is how to manage this kind of sudden rise of peaking in the second wave. Now, the most problematic thing is it's just not the number of cases which is coming into the thing. Do we really have the infrastructure to manage the number of people who are infected, right? Let it be mild. Mild can be managed at home. The moderate and the severe condition which require hospitalization as such, do we really have the infrastructure? The answer lies between what Dr. Ashwin and Dr. Jaffer rightly said is in between. It may be yes or it may be no. In case of urban areas where the infrastructure is there, the answer might be yes to some extent, not fully. Again, I'm saying not fully. To some extent, yes, we can manage the cases in the urban areas, but the real problem is in the rural areas where there's no medical infrastructure there, and probably as the virus is spreading now to the rural areas because of the migration of the people from the urban areas to the rural areas, right? Because of shutdown and all those things, that is the real challenge which you face now probably is the real challenge, where the number of cases which are rising up in the villages or the rural areas, that might be a real challenge for all the, I mean the Indian population as such might be a real challenge. How to manage the cases in the rural setup where there is no medical, I mean not much, I'm not saying there is not much of medical infrastructure lying out there now. And then on top of that, there are various protocols which are coming. Dr. Ashwin or Dr. Jaffer, you can correct me that there are various protocols popping up every day. The WHO one day says that remdesivir is not effective. On one day they say it is effective. On one day they say plasma therapy is effective. On the other day they say plasma therapy is not effective. I mean, there are various contraindications because nobody knows much about this virus. To be very frank with all, I mean, to be frank with everybody, I mean, let there be an expert virologist or whatever it is. We have seen that no, I mean, this virus is such a conundrum or such a, I mean, such a mimic that it can escape all the expectations of all the great virologists out here. And it's really, I mean, it's really a challenge to treat this because on one time, because the protocol goes on changing. That's one thing. The doctors who are on the ground who are treating these patients, they have their own set of guidelines to treat. I mean, please correct me if I'm wrong. They have their own set of guidelines because on their experience they are saying, okay, this is working, and they'll use this medicine. But suddenly somebody comes from WHO or something and they say this is not working. So this is really a conundrum for all the people who are working on the ground. So there is no definite guidelines. To be very frank, there is no definite guideline to say that okay, this is the protocol, this will work perfectly with this kind of population. Now, this would be a real challenge. This would be a real challenge in the rural areas where we don't have a proper medical infrastructure. That is one thing. And third wave, which everybody is predicting now. third wave, which everybody is predicting, can I just take a phone call because Vincenzo is calling? I think he wants to join the conference.
Yeah. Just
Yeah.
I'll
Can I
ask
just?
Dr.
Yeah. Can you
Dilip.
just?
Yeah. Just ask him to join. Dr.
Yeah,
Dilip, can you unmute yourself? Dr. Dilip is from Germany. And we are speaking about infrastructure. We are speaking about handling the children. We are speaking about so many things. Okay. Dr. Dilip and me, we both know in Germany, if a child is sick, the child is not hospitalized. The child is taken care at home. Right, Dr. Dilip?
Yes.
See, they don't run to the hospital when the child is sick. They take care of the child at home. So we see the third wave now also affecting the children in Germany. What do you have to say? Just share your experience, how they monitor the children at home rather than taking them to the hospital, because this would be a good message for India rather than to run to the hospital. If a country like Germany is promoting taking care of the child at home. Yes? Dr. Dilip, can you just share an experience how a child is taken care at home? Right. See, Dr. Dilip, like now in Germany, when somebody is COVID positive, we are not allowed in the shop. Nobody without a COVID negative, you cannot. So you don't see children. Normally, whether it is pandemic or non-pandemic, when a child is sick, there is a sick leave, both for the child and for the teacher. So they don't advise for hospitalization. Only very, very severe cases, even for the normal people, they are supposed to go to the hospital. Rest, everyone is at home. Ashwin, can you just imagine about this? A country like Germany, if there is a COVID positive, they are not running. They're not going 1, 2, or 3, even a normal flu infection. During May, everybody had pollen infection. Most of them will have pollen infection. Most of them will have hay fever. Most of them will have kind of, what do you say, a kind of an influenza. But nobody is running. Even nobody is running for vaccination. They are slow. They are calm. They are saying, okay, when it comes, when it comes. And they're taking care at home. So now my question, like, she is best in German, so better she can speak in German. Sorry, Dr. Dilip. Slowly, I answer on your behalf. So we had a discussion here, like Dr. Dilip and me in our slow English. Here, I had a friend, Sifa, are you there? She's a Turkish staying in Belgium. When her sister's children got infected, they were COVID positive. They were at home. There was no medication given for 7 days. Only teas, warm, isolation, washing of the face regularly, washing of the face regularly, tip sponging. Because the temperature was not there. So there was no Calpol, there is no paracetamol. I don't know why in India, a little bit of raised temperature, Calpol, paracetamol, antibiotics, steroids. Steroid was, I don't think so anybody here in Germany were given steroids. Oops. Okay, let us see who is this. So the main takeaway, like if we can make models for India, how to take care of the children at home. Like we are speaking, like Dr. Sunil is like worried what will happen in the villages. What I think in the villages, they will do better. Like Dr. Gur and me discussed, village has a space. You have space, you have ground, you can move. Movement in India in 10 by 10, where will the child move? In 10 by 10, there are 10 people. Now it's a lockdown, everybody is there. You know, so I was like on a WhatsApp video call and this person recovered, comes home, yeah, my test is negative, and hugging the children. Still he's carrying. Ashwin, as you are there with the policymakers and others, if we can send a message, see, yes, you can hug your children, at least maintain that it's not the social distance, it's a physical distance at home. So,
Dr. Amina, what do you suggest from the context of.
Wait, once again, we have Vincenzo joining us. Vincenzo, hello.
Hi, I am so sorry to be a little bit late, but
You are very...
just I would like to keep this opportunity to say really the welcome to all participants and to stress the importance that we give to the children always, because if we are capable to treat the children, we have the good adult society tomorrow. It's important, it's extremely important. And we need to focus all efforts in children health today with the prevention and with really the campaign for the major illness. In some countries, we have the high rate of the mortality for the pediatric population, and this is not good because we have the person sick tomorrow. We need to take care of children today. I insist in this concept. It's fundamental for me, this idea to keep today healthy children society. If we want to have the healthy society tomorrow. If we are capable to have the campaign of immunization to prevent the major illness and so on, we have more and more healthy population tomorrow, adults and elderly.
Vincenzo, we had till now the panel discussion. Dr. Ahmed is here. Dr. Ahmed Vincenzo is here. Dr. Ahmed shared there were 120 pediatric beds in his hospital, and they did not have even one mortality. You know, that is the strength of them to take care of the children, because the children are regarded as the future of that country.
Exactly. This is the reason I insist the idea we need to make the maximum of the efforts in order to have the good pediatric service. It's not only the people hospitalized. This is a part of the population. We need to make the campaign of the prevention. We need to make the campaign for the food. We need to make the campaign for the social favorable environment for the children.
Yeah, Vincent, so like now, everybody like pointers we had from Pakistan, we had from Turkey, we had from other countries also here. The pointers for the third wave are moving towards the children. So India, like we have Dr. Jafar here, who is heading a huge unit, and we have Dr. Ashwin here. They both are heading the two big units in India. Now, the question is still, most of them think the third wave is for the children. You are also seeing the third wave for the is most affecting the children?
The children, I repeat, we need to have this global vision of the children health and all stage, since the born until they become adults. This is very important. It's not only the health organization, but it needs the social organization.
Yeah, Jafar, you have any question? You have Vincenzo here. You had a question which you were starting, no? You can ask. Ashwin or Jafar, somebody was asking before Vincenzo started, sorry.
No, I was asking simply what, so if the care has to be done from home, then what are the specific actions that need to be taken for that? If that has to be made part of the treatment protocol or something, care of children at home, especially.
Yes, that's right. We have designed a protocol here under European Medical Association for the European countries. There is a design protocol. For example, you have a template in Germany, like if a child is COVID infected, what are the precautions? What is the diet? What is this? There is a defined. So everybody has it. The moment they get a COVID positive report, so this template goes to the how a mother or thing, and what is the breastfeeding, what is happening, how do you calculate? It's not suddenly putting the oximeter here, and what is the amount of steroids, what is the amount of this? Absolutely, the last chance, the last choice will be the medications.
You are right. This is the reason, Amina. It's very important to consider where is the children, is the environment. One children in Hamburg is completely different from the children, unfortunately, in India.
Yeah.
Yeah, because the food is different, the external environment is different, the water is different, the food is different. This is important, is to draw the attention of the children world. And this is very important for us to discuss about this, and the EMA is ready to support all the initiatives in this way.
Thank you, Dr. Vincent. So,
Okay.
Vincent, today the whole day we are having different presentations.
Okay.
Where every presentation we are focusing on the preventive healthcare for COVID and
Exactly. But consider
just before
what
we
is
start,
important.
we wanted to have a panel discussion. Ashwin and Jafar, we can take it from here. We can develop a module. We have enough of experts who are on the field, right?
Yeah.
If we, Dr. Ahmad's team entirely from Turkey, when, children are the one who cannot speak. Elders, they can say, okay, I'm having pain, I'm having chest pain. But what would we do for 5 years, 6 years? Because they cannot speak.
Exactly. This is the reason we need to consider
Forget
the
about
environment.
forget about the infection. They cannot speak the congestion in the mind. They cannot speak the bombardment. They are seeing their elders passing away. They are seeing their neighbors passing. They don't know death. My alarm was to bring a panel discussion here was the children did not know the meaning of death before the pandemic came.
Okay, try to do something, and at the end, we try to publish the statement of this meeting. Okay.
Yes, Vincent. So what we can do is here, Tahir, you're from Malaysia. Before we wrap up, we just try to wrap up. Can you just share what in Malaysia right now are you handling it? Because Malaysia is going up very beautifully for children. Absolutely preventive healthcare. I spoke to Dr. Go Ching Soon, who is a director, and she said absolutely they are trying the best the children not get infected. First thing. Yes, Dr. Tahir.
Yeah, actually, so initially the children were not affected, but of late, if we can see, there are certain clusters which have originated from the school itself. So we don't say that the children are not infected. Malaysia is having at the moment is like we are having quite a big surge at the moment for the last 3 to 4 days, where 6,000 and more than 6,000 cases have been reported. And the bad part is there are certain clusters which have actually originated from the school itself. So we don't say, saying that the third wave will affect children's or the third wave will carry a lot of children. So that is a false statement to me because it has already started. Okay, so we need to be alarmed that children have already started being infected with this virus. The wild variant, which was not so good infecting the children, but the mutant variant, so far the the variant which is circulating in India has not been reported so high in Malaysia. But still we have cases among children of 400, almost 500,000 cases in Malaysia. There are more than 60,000 children who have been infected so far, the school children.
What's the mortality, Tahir?
No, the mortality is very minimal, and only those children who have some kind of issues, health issues, have passed away. But overall, the mortality has been well
How many
controlled.
do you think were hospitalized?
No, the thing is in Malaysia, what exactly they are doing is anybody who is infected should be transferred to the hospital so that the chain can be broken. So that was exactly the part what Malaysia was doing, and they were too good with that. They have actually made some makeshift hospitals so that most of the patients, instead of in the community, they live in the hospitals. But of late, because for the past 2 weeks, the cases have been on rise. Probably, we don't know exactly, probably because of some variant happening, or maybe because people were a bit careless, but I don't say careless because we are protecting ourselves with double mask nowadays, and people are taking care of themselves, but still, the virus is in the community at the moment.
Okay,
So,
Amina, let me say something. If we are absolutely interested to have the report of this meeting today, and for the children, it's important to have the school, the family, the society, and of course the states. This is the point, the fundamental point. And when we talk about the children, we need to consider the food, water, and environment. Okay.
Amin, were you there?
I wish really the great meeting to everybody. Thank you very much, and let me know the report.
I'm coming back to you in 1 hour.
Thank you. Thank you.
Yeah. Amin, are you there? Because when Tahir, you told me the whole school was infected. You know, Ashwin, the entire school was infected. The entire
not the whole school was infected, but few clusters have been originated from the schools. So I mean now, yeah. So now I mean no, the clusters are not so big, because the good point is what exactly Malaysia is practicing is the moment there is some positive patients, they are segregating the patient from the community, taking them to an isolation center. So that isolation center is managed by the hospital itself. So this is what exactly happening just in terms so that the infection, the chain of the infection is broken. But to say that children are not so far not been infected is wrong. The children have started getting infected. Yeah.
So the third wave is exposing the children getting infected.
Yeah, I hope that will be much more bigger. What exactly we are seeing it now at the moment. So yeah, and if you can see,
scared, Ashwin and Jafar, see, everybody is scared to say, well, it will be much more bigger, like what we are seeing now with the children, but nobody is ready to. So let us start building up the preventive modules, and that could be the take-home message from this discussion. So thank you, Ashwin. Thank you, Jafar. Thank you, Dr. Sunil, Tahir, all of us. So we continue with our conference after this.
I just have one request.
Yeah.
To Dr. Gur.
Hmm.
He was in fact giving a lot of actionable points,
Yeah.
like what we should do, and especially on the what you say, the diet side, what are the kind of things that could be given. So if he could just jot down these points and send it across, it will be quite helpful.
Yeah,
We'll give you
absolutely.
perfectly.
Yeah, absolutely.
We'll give you a perfect, breakfast, lunch, dinner options also for the children. The whole day of the conference, we have different aspects here. We have music therapy, we have counseling, we have the whole day. We have about 15, 20. So I will forward you all the presentations, or I can catch you on Saturday or Sunday, share your laptop, copy the whole folder and paste it on your laptop. So I can give it to you and Ashwin.
Because the way he was describing, it appeared that he was describing on both on preventive, in the sense those children who are not yet infected, and at the same time you were discussing about the dietary plan for those children who are infected also.
Yeah,
and one
I think
final point I would while hearing him speaking, especially Dr. Gur, when hearing him speaking, talking about making children sleep early, all those things are becoming a little difficult now because of lockdown. We are going more into online education. So about 2 years ago, I have disconnected my internet at home so that children are not exposed so much. Same person today is giving a laptop, a mobile to the children and asking them to log on to that and use it. And this is actually taking a toll on their nightlife, in the sense sleeping late. So these are going to be some behavioral challenges on behavioral changes with children, and we will definitely have to work with them, and educating parents to do some sort of home checkup on a regularly basis and look for various danger signs in children is another thing which maybe some sort of a protocol could be written on that. Thank you.
Jafar, can you give us 2 days? Monday, we will be with the document, and Ashwin, you can arrange a press conference for India. So I will have only 10, like Dr. Gur and Vincenzo and all of us, with actionable points. I'm going to put actionable points for COVID pediatric isolation.
Sure, let's do that.
So we can have a press note and we can prepare a document which can be circulated all around the newspapers in different languages. Actionable points, what they can do. Like Dr. Gur was saying, Organon. Where will we start searching Organon? We get it only in the Pizza Hut in India, right? So let me check out what is available right now there. We can ask coriander instead of parsley. We can ask mint. We can ask methi, kasturi methi, fenugreek instead of Organon. So let me try to prepare a document with Dr. Gur and other experts here together. And let us have another press meet or something on Monday or Tuesday with actionable, let us put it as an actionable take home or actionable COVID helpline for pediatrics or home isolation. So probably that would be good. So let us combine all together. And of course, the conference will still go on, and we have our presentations now.
Yeah.
And thank you so much.
Professor Amina,
yeah.
Professor, a small point that my colleague Oni, she could not connect to the sound, but she texted me, and it's very true. It's about vitamin D, because many of the kids that are having an acid diet, they are hard to absorb the vitamin D, even if they go to the sun. And we absolutely can connect the low vitamin D to low immune resistance. So boosting vitamin D, which they cannot get only or solely from sun because of the diet, is also crucial for decreasing the intensity of the disease and can help with the better healing. And it's not toxic, because most of the kids that we are checking, at least here in Israel, are deficient.
Yeah. Even in India, because of lockdown, they are not going out. Where is the sun?
Even if they go out,
yes,
their diet is so acid that they cannot absorb it. Even if they eat meat few times a week, they still lack of B12. This is a problem of acidity from young age.
This is a problem of absorption of the food.
Yeah.
See, we are eating rich food in the sense is not spices, biryani or halib. It's not that. That is not the rich food. The rich food is which absorbs into the body. Allow the food to absorb into the body.
Mm-hmm.
Right? So how do you have the food absorption into the body? That is more important. Yeah. So yes, Dr. Good. Yes, Dr.
Just a small thing about the food is the food should be simple, it should be digestible and absorbable.
Also excretable.
And excretable. So it should contain all the minerals, vitamins, and all those things in such a way that it will not only boost up the immunity of the child, also it will keep the child in a healthy condition. And as Dr. Jafar Saf rightly said, that because of the internet and because of the online program, the children are not getting enough of sleep because they are sleeping late. Probably that is also affecting a little bit on the children's health. That is one thing. Second thing is isolation of the children who are already infected. So if you want to isolate the child who is already infected, that's another big headache, because the children will not leave their parents, and then there is a difficulty of handling the child. Right, so that's one thing which I don't know, Dr. Tahir, if he can at the end of the day tell us how exactly they manage this, because this is the most important thing when we want to isolate the child, because they raise the question of isolation of the child. You cannot isolate the child without the parents, because the child would be uncontrollable if the parents are not there with them, and that's a bigger issue which we have to face. And when the child number gets infected number goes up, and then you have to accommodate the parents also along with the child for isolation, then it becomes that much more difficult for the authorities to handle both of them, the parents as well as the child. So it is a dynamic kind of a situation which is evolving. Probably over the period of time when we have a discussion on this conference, we would come out with a dynamic plan as to how to manage this kind of a thing. Both Dr. Ashwin as well as Dr. Jafar would probably, as well as Professor Amina, as well as Dr. Gur and Dr. Tahir and Dr. Ahmed would shed some light as to how to take this forward. Right, because we should have, as Dr. Jafar rightly said, it is just not whether they're infected or not infected. How to manage these people who are infected. Right, whether it is mild, moderate, or severe, that is a different kind of how to manage these children in a proper way, because we don't want a child who is infected and whose lung disability is so much that is not compatible with the life at the adult stage, right? So that's what we don't want, such kind of a comorbid kind of a problems happening. So we would like to have a dynamic kind of a plan where there will be less kind of a morbidity as well as mortality. So yes, the experts would do that.
Thank you so much. I think we got the home message So we got some homework from Jafar and Ashwin, especially from Jafar. Jafar, next time I will not call you for panel discussion. You'll give me homework. I will connect with all of them.
That's what we are supposed to do.
Yeah. What, Jafar? I'm
That
supposed
is
to do the homework.
That is what we are supposed to do at the higher level, to make others do some homework.
Yeah, we are living
and
outside India, but you make us do the work for the home country, which is homework.
And don't forget that I was heading education department, school education for 4 years.
He was a commissioner of the thing, and we did a lovely workshop. We did live activities, and Jafar, seriously, we have to do it back again. Let the pandemic be over. I wanted to present those activities today in the conference, but that 1 hour is taken up by this panel discussion. Now, Jafar is saying that would be good, Amina. You would have done that exercises here with others. So, thank you, Jafar. Anything else, Jafar and Ashwin, before we wrap up and we start the presentation? Dr. Dilek's presentation is next. Dr. Dilek, we make you the co-host, and can you make the presentation from your laptop?
Yes.
Okay. So we make you the co-host and we can have your presentation. So thank you, Jafar and Ashwin. Dr. Gur, can you please make, she's a co-host. Perfect.
Being done.
Yeah, Dr. Dilek, you can share your screen and you can have the presentation. After Dilek's presentation, we can run Dr. Anthony's presentation. It's 9 o'clock and we at 9 is Dilek's presentation, right?
It's okay.
Yeah.
My presentation is about childhood obesity.
Yeah.
One moment, Amina.
Yes, my dear. It is there. We can see, Dilek.
So, about childhood obesity.
Yeah.
Definition, BMI, body mass index, is the most widely used parameter to define obesity. In children 2 years, obesity is defined as body mass index 95 percentile, body mass index between 85 to 95 percentile falls in the overweight range. Weight for high to 120% is considered obesity. Prevalence. It is a global public health problem, sparing only dramatically poor regions with chronic food scarcity. Prevalence is 31% in age group of 16% in age 6 to 19 years. Etiology and environmental factors increased consumption of high carbohydrates, beverages, fast food, increased snacking between meals, decline in levels with physical activity, increase in sedentary activities, high pressure for academic performance, socio-economic status, race, gender, maternal education level, parental obesity, prenatal factors like weight gain during pregnancy, high birth weight, gestational diabetes, decreases glucose tolerance and insulin sensitivity due to alterations in glucocorticoids levels, synthesis of orexins, peptides in lateral hypothalamus in increasing feeding. Genetic causes, Alstom syndrome, Beaumont syndrome, Carpenter syndrome, Cohen syndrome, Down syndrome, Turner syndrome, Prader-Willi syndrome, Fröhlich syndrome, endocrine causes, monitoring of stored fats, control over appetite, satiety occurs toward neuroendocrine feedback loops, lichen, habitus, tissue, CNS, and GI tract. And someone from the diet, stimulation appetite, ghrelin, promoting satiety, cholecystokinin, glucagon-like peptide 1, peptides from the adipocytes, adiponectin, leptin, someone from the brain, neuropeptic, agouti-related peptide, orexin, stimulate appetite, melanocortins, alpha melanocortin, stimulation hormone, satiety. Someone from the brain. Endocrine causes, Cushing syndrome, growth hormone deficiency, hyperinsulinism, hyperthyroidism, pseudo-hypoparathyroidism, constitute onal opacity, no organic cause. These children are 12 for age. Normal development opacity is proportional. Hypothalamic opacity following surgery, radiation, tumors, trauma, infection, drugs, anti-epileptic drugs, steroids, estrogen, atypical antipsychotics, comorbidities, diabetes type 2, hypertension, hyperlipidemia, non-alcoholic fatty liver disease, cirrhosis, risk of chronic inflammation, obstructive sleep apnea, orthopedic complications like blunt disease, mental health problems like low self-esteem, depression, eating disorders, metabolic syndromes, PCOS. Evaluation identified as a part of routine medical checkup, perform a detailed physical examination, cutting growth checks for weight, high BMI, consider possible medical causes of obesity, a detailed history of family eating and activity patterns. A family history of adiposity and obesity-related disorders, laboratory testing to identify comorbid conditions. Cardiovascular disease and symptoms. Neurologic disease and symptoms, pseudotumor, cerebral high stages, vision stages, papilledema, orthopedic blunt disease, stiff bowing of tibia, knee pain, Lyme, psychological behavioral complications, anxiety, depression, low self-esteem, disordered eating, signs of depression, worsening school performance, social isolation, problems with buying gold. One statistic about body mass index for girls 2 to 20 years. For boys, the same. Intervention, nutritional, exercise, cognitive behavioral therapy. Meals should be based on fruits, vegetables, whole grains, lean meat, fish, and poultry. Gradual approach to cut down calories. Family support is crucial. Traffic light diet plan groups foods into course which can be consumed without any limitation. Green in moderating, yellow reserved for infrequent treats. Red can be adapted to any ethnic groups, regional Kreisen. Increasing physical activity contributes to weight loss, decreases risks for cardiovascular disease, restriction of screen time to no more than 2 hours a day in children to 2 years old, no television for children less than 2 years. Pharmaceutical therapy, someone of drug, mechanism of action, side effects. Bariatric surgery for adolescents with body mass index to 40, after attaining complete skeletal maturity, suffering from medical problems associated with obesity, after they have failed 6 months of multidisciplinary weight management program.
天呐，姐姐们！
好，声音弄小一点。
沈老师，您坐这边吧。
Physical activity, reduce screen time, promotion of breastfeeding, introduction of infant foods at 6 months with focus on cereals, fruits, vegetables, introduction of lean meat, poultry, fish later in first year of life, avoiding highly saturated beverages and foods. Family approach frequent snacking to be avoided, limiting screen time for children, 60 minutes day of activity for children, and court walking to school, use of mass media. Thank you. And this was my presentation.
Thank you very much. Okay, Professor Amina. Does anyone have a question that they want to ask? Anyone want to ask any questions?
Sorry. I'm back. I said sorry. I'm back because I just attended a phone call. Yeah. Dr. Dilek, she has a vast experience in eating disorders. Okay, Dr. Aisha, you can ask her in Turkish. She can answer you in Turkish. We have no problem. She can speak good Turkish. Dr. Aisha, if you want to ask anything, you can ask her in Turkish.
Merhabalar Dilek Hocam.
Merhaba.
Nasılsınız?
İyiyim, teşekkür ederim Doktor Ayşe Hanım. Siz nasılsınız?
Çok şükür bizler de iyiyiz. Soruları size tercüme etmeye çalışacağım inşallah.
Tabii ki.
Have you any questions?
No, Aisha, you can ask the question if you have to her in Turkish. Dr. Ahmed,
okay.
We have our German colleague talking to you in Turkish.
Ahmet Hocam.
Buyurun.
Dilek Hoca'ya bir sorunuz var mı?
She is our German colleague and you can talk to her in Turkish.
Can you repeat again, please? I couldn't understand you.
She is our German friend and she can talk to you in Turkish.
Okay. Merhaba Dilek Hanım.
Merhaba.
Bir kendinizi bir tanıtır mısınız? Amine Hanım bulduğuna göre sizi hakikaten kapasiteli bir arkadaşsınızdır yani. Buyurun.
Aynı günde yaş gününüz var zaten.
Buyurun.
Amina'yla.
Evet. Bir kendinizden bahseder misiniz? Nereden gelir, nereye gidersiniz? Bir öğrenelim.
Adım Dilek Kılıç. 42 yaşındayım. Münih'tenim. Heidelberg'de 3 senedir yaşıyorum. 2 tane ofisim var. Biri Heidelberg'de, biri Mannheim'da. Süş analizi üzere.
Ne üzere?
Süş analizi süş analizi biliyor.
İngilizce söyleyin. Türkçe.
Süş analysis. Süş
Tamam.
analysis.
Tamam. Evet, dinliyoruz.
2 tane ofisim var.
Tamam, çok güzel.
Başka
Nereden eğitim nereden?
Ellen Hancock College.
Kolejden.
2012.
2012. Ya medical doctor musunuz yoksa?
PhD.
PhD. Tamam.
Aynen.
Tamam, çok.
She has two beautiful
psikoloji.
Evet. Çok memnun olduk. İşte
Ben de çok memnun oldum.
Amina'la how many years we are know each other, Amina? 5 years, 6, 8 years? 5 years. Okay. Tamam, çok güzel ekibe katıldınız. Teşekkür ediyoruz. Katkılarınızı bekleriz.
Ben teşekkür ederim. Hayırlı cumalar.
Sağ olun. Çok teşekkürler. Sağ olun.
So she is working all the time. She has 2 clinics on psychosomatic and she is a PhD. She is so much into research and she's so much into research of eating disorders with the Turkish children.
Okay, Amina.
Thank you, Amina.
Now,
It's very good.
Amina, now one side, Amina, the other side, Dilek. Who is the more hard worker? Also, Amina is very, very hard worker. Which is the first?
Work. Only in the middle of the night I come. I say, yes, Aisha, yes, Dr. Maghfirat, yes, start your presentation. And then Maghfirat and Aisha say, what you do to the hair? I say, what I do to the hair?
Because the Dilek, yesterday night, Amina sleep only 4 hours. So
6 hours.
And I 2 hours.
Really? Oh, very nice. Very nice. Okay.
Dr. Ahmed, in Germany, everybody will work till Friday. Saturday, Sunday, nobody want to work. But I work on Saturday and Sunday because Iran, Dubai, Malaysia is working on Saturday and Sunday.
Okay. Okay. You know, I stay in nearly 6 months in Mannheim and Mainz from urology clinics. And then in Germany, the Friday evening, the life is stop. And then till Monday morning. But who are working? Turkish citizen. So there is one street. My son is 2 months for some stage to went to this city. I forget the names. All the shops owner is Turkish.
Only Turkish, yes.
Yes, all the doner, the meat. I said, how did you buy all this? They said, all the German is sleeping in Friday to Monday. We are all working. So this is a different style, Turkish style or Oriental style.
Only Turkish.
Yes, is it right? Isn't it? Is it right? Okay. Thank you. I'm very happy to meet you. And then, inshallah, we will do some nice cooperation and studies. Thank you. Thank you for your supporting.
Inshallah.
He sent me the presentation the 22nd of May, and so 22nd of April. She sent me the presentation 1 month before for today's conference.
But in the Oriental style in Turkey, we sent our presentation last night.
Today morning. She's Turkish. I am Indian.
Okay, okay. Today morning or now also the apitherapy Timuchin, he didn't send yet, isn't it? No, he's not yet. Okay, you must have it our working style, Amina. Okay.
No issues. Now we have our Chinese, Dr. Gur, you are going to present her presentation?
No, it's on your. I send it to you. You have it on you?
1 second. You send it to me on the email?
Yeah. Dr. Shwana, you with us?
Yes.
They had connected.
Yeah, she's there. I can see her.
Yeah. I want her attention.
Dr. Gur, which mail did you send it?
Just a second.
Give me, no issues. We have. I don't see on my mail. Can you resend?
Yeah, of course. As we speak.
Or we can make her the host and she can present directly from there. I'm waiting for the music therapy.
Xuanishen, ni hao.
Ni hao. Unmute. Yes. Hello.
Hello. Welcome.
Ni hao.
Thank you very much. Thank you very much for joining us today.
Yes.
It's a pleasure. Can we make you the co-host and you can run the presentation from your computer?
Yes, okay. Yes, we can.
So in a second, I will make you a co-host, okay? And then you can run it. Do you want to say anything before we start?
We give the presentation first.
这个要共享吗？是吧？
I'm waiting for music therapy.
The screen has been shared with.
Just a second. You are under, I just want to see under which name.
The last one. The last one. Yeah.
I see.
Yeah.
Everything is okay.
Yeah.
So, okay, I make you co-host, Dr. Schwan. It's okay. You can see, and then you can share easily from your screen the video. Do you want to introduce yourself?
Okay, can you see the video?
Not yet. You have to choose it on the. You first have to choose the screen and then to make the share. Share screen. You can do it.
Meeting personally is so nice, Dr. Gaur. When can we meet personally?
Inshallah.
Music.
那个会议的这个不是，这不是会议。
Professor Amina, if they have problem, do you want to try to run it from your place?
Yeah. Can you send it to me?
It's on your email.
就这个应该就对这个。
然后共享屏幕，点一下这个共享。
Okay.
Okay, great. We can see. Before you start, Dr. Schwan, do you want to tell us anything? You want to introduce yourself, or we start and then we talk? 双医生，你可以给我们介绍，给大家。
Okay, in Chinese. My name is 宣肖布，然后我是来自于浙江省中医院儿科主治医师，我是我们浙江省宣氏儿科流派传承的一个第4代的传人。那么今天很高兴能跟大家分享一下我们流派关于治疗中医治疗儿童抽动障碍的一个经验。
Okay, so I will translate to everyone. She's a specialist from Zhejiang Provincial Hospital in China. It's one of the latest hospital in China, and she's standing in the Department of Pediatrics, and she will share from her experience. She's one of the top doctors in the county. It's our pleasure to have you in our meeting. Thank you very much, and to collaborate the cooperation with China. Go ahead, you can start the presentation. Thank you. We don't have the voice.
Voice 没有声，有，它这里没有声。
Just we cannot have it. I will try to have it from here. Can you stop it? And I will try to run it from here. Okay, because we cannot have we don't have the voice.
Can you hear the video?
No, we can only see, but we hear very low voice. I will try to make it from here in a second.
Didi, you can hear our voice?
No. 听不到.
You mean the presentation, you can't hear the voice.
Exactly.
But if we talk, we can hear, right?
Yeah, we cannot hear this. I will try to open it from here.
Okay. If we talk, we can hear each other, but the presentation you couldn't hear, right?
Exactly. The problem is the download from here is very slow. Can you try to make anyhow something at your end so maybe we can hear you?
It shows, if I want to download, it shows that it will take 10 days.
Maybe you try to do something.
Can they present online? I mean, we can just move the slides. Can they present online?
Can I do one thing? Can I run Dr. Anthony's presentation by the time we resolve this?
No, just a second. Maybe the we cannot. It's problem to download in our end, Dr. Schwan. Can you maybe give it the lecture? Yes. Just show the PowerPoint and you can talk live on the same time. It's possible for you? Just to share the presentation. And you can just share. You can just share the. You can just share the screen.
No problem. Okay, you just 1 minute.
No problem. If you can just put the PowerPoint on your screen, you can just move by yourself.
Okay. You can hear our voice, right?
Oh yeah. Absolutely.
Yes. Okay. So we instead of Dr. Xuan, and so we another Dr. Shi, we'll just read through. Then after that, if we have questions, then we discuss. Okay? Can we?
Yeah. Absolutely.
Okay.
But,
Start from Qing Dynasty. Okay.
Xuan's Pediatrics started from late Qing Dynasty. It has over 100 years history and is famous for treating infantile convulsion in Hangzhou. Now, Xuan's Pediatrics becomes the main academic school of pediatrics in Zhejiang and enjoys a high reputation in treating critical, difficult, and complicated diseases in children. Xuan's Pediatrics specializes in treating convulsion with high fever, epilepsy, tic syndrome, hyperactivity disorder, leg rubbing syndrome, high blood lead, refractory asthma, autism, and so on. These are the founders and inheritors of Xuan's School Pediatrics. Because of the time limit, I will not give introduction in detail.
Maybe you can let the video run so the slide will change and then you can continue.
Okay. Dr. Xuan Guiqi, he is a professor, chief physician of Chinese medicine, tutor of academic experience inheritance of national senior TCM specialists and famous TCM practitioners in Zhejiang province. Now he is the consultant and standing member of the first committee of Academic School Inheritance of China Association of Chinese Medicine, researcher of Zhejiang Provincial Academy of Famous TCM Practitioners, pediatric consultant of Zhejiang Association of Chinese Medicine, and head of Hangzhou studio of Xuan's Pediatrics. The experience of treating child tic syndrome is the treatment for child tic syndrome is a successful example of Science Pediatrics academic thoughts in treating modern diseases, Professor Xuan Guiqi has unique academic insights and rich clinical experience in this disease. Child tick syndrome is a neuropsychiatric disorder that occurs in children and teenagers. It is characterized by involuntary, repeated, sudden, rapid motor tick of one or more body parts with or without vocal tick.
Can you just change the slide so we can see the slide itself, because it's standing on the same place? Maybe you can just play and change the slide.
We're changing the slides.
We already changed the slides.
It is changing.
But you sharing the screen, we cannot see. You have to change you have to share the screen of the slide. We see the video.
Okay.
Okay, you just reshare. I'm sorry to disturb you. Just reshare the screen. Okay.
That's all right. That's all right. I'll try.
Yeah, stop sharing and share again the screen, and then we can see it, because we have the frozen image of the video. I'm very sorry for the, I apologize for the video. We cannot run it. Can you hear me? We can't hear you.
Yeah, the voice is like, yeah.
Oh yeah, now it's okay.
Yeah. Yeah.
Now we can see it. Excellent.
Yeah.
This is perfect.
Excellent.
Yeah, we can. We have enough time. Dr. Gur, I tried to download the Chinese presentation. It's getting stuck.
Yeah. Dr. Schwan, can you hear us? You can continue with your screen. We cannot hear you. Dr. Schwan, can you hear us? We cannot hear you. Oh yeah, now we hear you. Now it's okay.
Oh, okay. Okay.
Now we're good. We apologize for the technical difficulties. You can continue now.
It's all right, no problem. No problem.
I apologize. Thank you.
No, it's okay.
It's okay.
Thank you.
I'll start from this slide.
Excellent. Thank you.
First, internal cause should be treated from the liver. Among 5 Zhang organ disorders, child tick syndrome has close relation with liver. Any of the 5 Zhang organ disorders can involve liver. Internal stirring of liver wind leads to the outbreak of tick. Number 2, as for the external cause, external wind is highlighted. 60 to 70% of child patients have symptoms of exogenous diseases, or they are susceptible to tick syndrome, induced or worsened by exogenous pathogens easily. The lingering pathogenic wind attacks lung, invades heart and liver, and causes liver wind stirring inside and repetitive attacks of tick, which is difficult to be treated. Number 3, wind phlegm, invading meridians. Pathogenic wind combined with phlegm invading meridians is the main cause of chronic tick that is difficult to be treated. So the treatment should be eliminating wind, meanwhile regulating Qi and clearing phlegm. We use Chaihu and Zhike to regulate Qi, use Changpu and Dananxing to clear phlegm, use Weilingxian and Chuanxing to promote blood circulation and remove obstruction in collaterals. Number 4, coordinate yin and yang for chronic disease. For children with yin-yang imbalance, pathogenic wind is more difficult to be eliminated. Clinically, this kind of patients manifest as personality disorder and improper behavior. The treatment should be rebuilding the balance of yin and yang first. The formula Chai Hu Hui Zhi Long Mu Tang from Treatise on Cold Damage Diseases is applicable. It has achieved significant effect in clinical practice. This is the empirical formula, 宣氏抽动 formula, and the below are Chinese herbs in this formula. You need to take a photo. I'll continue. The modification is for frequent blinking, Gouteng and Baijili are added. For stuffy and runny nose, Baizhi, Cang'erzi, Ebushichao are added. For tick of the whole body, Luoshiteng is added. For upper limb tick, Sangzhi is added. For lower limb tick, Ningxi is added. If tick of abdomen is more obvious, Mugua is added. For patients who often clear the throat with a refractory abnormal voice, Tiandong and Jiangcan are applicable. For food stagnation and obesity in children, herbs of resolving dampness, promoting blood circulation, and removing stasis are applicable, such as Erchentang, Shanzha, Honghua, and Taoren. Now, the incidence of tick syndrome is constantly increasing, which is closely related to improper diet. Therefore, in addition to medication, diet control for child patients is also very important. It is important to eat well, but not eat too much, not to take cold food, night snack, food out of season, and food that contains hormones. It is also reflected in an old saying in China, the more you eat, the duller you become. At the same time, doctors should advise patients that swimming is not applicable for children with tick syndrome in case of cold qi entering the body through eyes and nose to bring up the disease. Avoid excessive exercise and blowing wind directly when sweating to prevent pathogenic wind invading and lingering in the body, which is hard to be cured. Thank you for listening.
Dr. Gould, is it possible for us to ask her?
Okay, are there any questions?
Yeah, absolutely. Thank you, first of all, very much for your presentation, and we apologize again for the technical difficulty. Today we have people from most of the Asia, actually from China, Malaysia, India, Pakistan, Iran, Turkey, Belgium, Germany. and we're discussing about pediatrics and about COVID-19 and the upcoming flare-up of the COVID-19 with children. We will be happy to hear if you have any experience regarding the COVID-19 with children, and what is the condition now in China with COVID-19 in children, because we see more kids are getting infected with COVID-19.
就是新冠的话，从我们是中医还是西医？中医啊，从我们中你新冠没有经验，因为我们这边没有新冠。但是呢，你从这个角度，如果说小孩子得了新冠的话，应该从哪方面去治疗就可以啊？因为我们没有新冠的。对，因为就是说我们医院是不是新冠的定点治疗？那么可能就相对来讲，接触这部分病人还是比较有限的。那从目前的一些国内的情况来看，那么儿童发病如果新冠的话，我们还是主要考虑中医，主要考虑还是从一个热和毒来考虑的。那么主要还是以清热解毒。那么初期的话，那么如果是
You're frozen.
Good, you have to translate.
I will. The second that they froze they said that this hospital, it's not a main point for treat COVID. But when they do have cases for kids, they mainly look at it as a kind of heat and toxicity in children, and this is the way they treated with the Chinese herbs. I don't know why they were cutted, but her answer was cut in the middle. You heard the question. I think they can give a small light, but I think there is a problem in the connection. The big brother from China is sometimes making the internet a little hard.
Dr. Gur, nobody can speak about anything, okay? So we will wait for them to join and we have the questions. I can laugh to the maximum extent.
I will wait for them to introduce the condition.
They're connecting. Wait.
Yeah, I think they can introduce the condition. So, because I know that recently I talked with some colleagues in China yesterday, and they have almost 70 cases of the Indian variant in different spots in China that appear in few days, and they went into a very severe lockdown. And the isolation in China is 2 weeks, and the facility when you enter the country, another week to the county, and another week after you reach inside. So now it's 1 month of isolation to enter China.
Dr. Amina, you cannot go to China.
I can tell you one of my patients is a pilot, and when they're going there, they said that when they make the examination, they bleed after the examination from the nose. They check it, they check it hardcore. Now the American pilots have complained. So the next time they land, it's a real story. The next time they land, they check it from the ass. So you better not. You better
No,
not.
we are not joking. We are not joking.
No. You can find the virus much longer in the.
Yes.
Yeah. But
I need to what? I call somebody to join today. Early morning, 6 o'clock. I wake up. I call. I'm the WeChat. I look at the WeChat. I try Bismillah. I click on the WeChat. It connected. I said, can you come? He said, do you want me to be thrown out of China? I said, okay, fine. You don't come to the panel discussion. I call another.
Okay.
They're back.
Okay.
Dr. Gur, the question. My question, please, in Chinese. When children have liver toxicity, right? When you want to cleanse the liver, what is the best way in the home? You just ask them this little question.
Did you get the question? Did you hear me?
We didn't get the question. Can you
Okay,
repeat?
so I will ask it. I will ask it again in English. Professor Amina, Professor, you can hear me? Professor Amina wants to know. Dr. Schwan talked about liver and heat toxicity for kids, right?
Mm-hmm.
So what is the best way at home if kids get a COVID, they got the coronavirus, and if they're home, what is the best herb, the best remedy to use home?
对于如果是你听明白了啊？对于儿童得了新冠肺炎，在中国用什么药或者用什么方法，就是对这些孩子最好，就是治疗方法。
小孩子得了新冠，然后他在家里用怎么样的方法对他们，比如说中药调理啊，或者生活的起居的调整啊，怎么样方法对他们是最有利的？得了新冠在家里 at home。
对，就是在家里边，就是在家里边有病人，就是专门是这个儿童，就是患者这个 COVID-19，怎么就是在家里边，就是在家里边，不是在医院里边，那就是怎么办？
那首先一步就是肯定是要居家隔离，那么跟你亲密接触的你肯定是要隔离的啊。那么第二步的话，那我们这时候可以发挥中医中药的优势。那如果对轻症的轻症的如果是新冠，如果医疗资源条件有限的话，那么完全可以是用中医来达到一个比较好的预防治疗以及后期的一个调理的一个那个效果的。
比如说你可以跟我们说哪种中药你可以用在家里边预防？
那如果是对初期的话，我们可以就是一般就按照中医的辨证论治，可以就选用银翘散。那包括我们省中医院自制的一个复方大青颗粒啊，对于一般的病毒性感冒，因为新冠它也是属于一个病毒性的感染嘛，都是有比较好的预防和治疗效果。那如果是到了中期了，那你如果症状这些比较重了，那么我们银翘散可能就相对达不到这个治疗效果。那么中医来讲，可能就用麻杏石甘汤这些，或者是千金尾金汤这些那么到后期，如果你新冠基本上已经恢复了，那可能后期还有一点我们中医讲究阴虚的那些症状，那么可以用沙参麦冬汤来进行一个调理。
Okay, 谢谢。I will translate what she said because first of all, she said the first thing is isolation. This is the first thing, and I think China is, we just talked about it, is the professional about isolation, moving from place to place. It's almost impossible, but this is, I think, the way they get hold of things, they stop it. And in Chinese medicine, differentiation is very important. There is not one medicine for all. So a very common thing for, we said for acute condition, if the kid is in excess of heat and wind, they use Inchiao-san, which is Lunicera japonica flower and Forsythia fructus as the main herbs with other herbs inside. It's a fixed prescription, can be easily found if you Google it up. And for a patient with some inner heat in the lungs, excess heat, big cough, yellow phlegm, difficult in breathing, they're using prescription that use the ephedra, sinica, gypsum, the mineral, together with licorice, and another herb that I forgot and the seeds of the actually apricot, the inner side of the seeds. They use it together, all four together. It's a very classical prescription that actually was used in the 50s and in the 60s when there was a meningitis epidemic in China and Western medicine couldn't help. This kind of prescription saved many kids' life from meningitis. So now they use it again. For kids with low constitution, more thin, that they suffer from lack of fluids in the body, they use a prescription that use Opiopogonis root and other herbs to nourish the stomach. So in Chinese medicine, it's very common to go in China to a pharmacy and you can get the patent medicine, and it's in the culture. You don't have to necessarily go to a doctor or to the hospital, because many people know if some symptoms start, the throat is painful, or there is some fever, they can take this kind of prescription. So I think for that, we see that the use of herbs in Chinese medicine that helps a lot in prevention of the COVID among kids and in the general population at all. Anyone have more questions for Dr. Schwan? Professor Amina?
Are they using a particular, I mean, are they using particular concoction or concoction of herbs based on the severity of COVID? I mean, is there any particular formula they are using depending upon the severity of COVID?
就是我前面介绍的都是我们就是中医的一个传统的方子，然后治疗。因为新冠就是从我们中医的辨证4诊来说的话，就是相当于我们临床所见的一些病毒性的肺炎。那这些方子的疗效也是非常好的。
Okay. She's explaining that in Chinese medicine, again, there is no magical prescription on one prescription for all, but it should be differentiated as well in every other traditional medicine. If it's Unani, Ayurveda, Persian, we all have to differentiate. I was listening to one of their specialists because the delegation to Italy, when the first wave happened, their hospital sent their specialists to Italy. And in the first wave, they use a certain prescription that we can upload later. And they were the hospital that taking the first action in Chinese medicine in Europe to prevent it. But there were a few problems. One, the European had to grasp to use the herbs to treat themselves. It's about tradition and confidence in the medicine. This is one thing. Second, the first wave is very different from what's happening now. We can see that from, and their doctor, I forgot her name, she gave an amazing lecture, and she introduced that from county to county in China, the symptoms of the COVID are different. And this depends on the weather, on the diet of the people, on the constitution of the people. So they have different symptoms. So again, we live with differentiation, and this is what Dr. Kwan just told. Thank you very much, Dr. Schwan. It was interesting, and we really hope to see you from the hospital again in the next conference. It was a pleasure. Thank you very much. Hope you can stay with us and to take part. I know it's dinner in China very soon.
Thank you so much. Even though there is a time difference, it's already evening there, for giving your time, managing the time difference. Dr. Good, like next conference is on oncology, right? So if the colleague from China, like now she presented, if we can have a case presentation and with certain pediatric oncology, especially with the skin cancer in the children, if it is possible, and if we can have a very small presentation, just 5 slides or 6 slides, how traditional Chinese medicine applications can help in skin cancer. If it is possible, if she can give a case presentation for the next conference.
Yeah, absolutely. For next month, it will be, I see the boss behind saying that yes, for next presentation.
The boss behind saying yes. Where is the boss?
Yeah, the boss is behind. This is the strong woman behind everything.
What's her name?
Introduce yourself.
Please.
Hello. Very nice to see you. My name is Chen. I study Chinese medicine as well. And also I'm a program organizer for foreign students to come to China, study Chinese medicine. You are very welcome if you have a chance to visit China and study a bit of Chinese medicine.
For sure. I was in Wuhan, Urumqi, Yuan, Shanghai in 2016, 17. So it is history, it is BC, it is before COVID.
Yeah,
so after COVID, I think I will come there in 2030 when I am old, when I have a bit.
Actually, we doctor.
You are very young. It's too far. You are getting old. Still has a long way.
45. So I'm getting.
It's very young.
No. I'm getting old. So when I am 20, 30, I will come to China. So another 7 years, I will wait for everything to go.
Some people is already 70, 75. They still come to China to study Chinese medicine, study acupuncture. It doesn't matter how old you are. Just if you have interest.
Yeah, I just want to add that this hospital is responsible for distribution of knowledge on the Silk Road. And actually, Dr. Chen is responsible, and we are connected in the clinics. We actually have facility that we can consult with the specialist in the hospital in China and to bring the patient before the COVID area for consultation. This is something very special that we're running between Israel and China, and as well as other countries to improve patient quality and fast diagnosis. Dr. Chen, thank you very much. Dr. Schwan, thank you very much.
Dr. Good, Dr. Aisha, I have the presentation for the next presentation. So shall I run?
Yeah, we can continue.
Can you see?
Yeah.
1 second.
Hello to everybody. First of all,
1 second. Yeah, I run.
thank you to the organizing committee for giving me opportunity to speak. What is a pediatric urologist? Pediatric urologists are surgeons who can diagnose, treat, and manage children, congenital and acquired renal and genital problems. Pediatric urologist specialist is obtained after 3 years training, taken after urology or pediatric surgery residence. Disorders of the genital system are commonly seen in infants, children, and young adults. These issues include socially acceptable illness functions, renal function, malignancy, and future fertility. We are interested in the treatment of many congenital and acquired genital diseases in children. Evaluation and management of body disorders, respiratory infection, and urinary tract infection that require surgery. Surgical reconstruction of the urinary tract, kidneys, ureters, and bladder, including genital abnormalities, hypospadias, and ectasia. Surgery for growing conditions in childhood and adolescence, appendicitis, hydrocephalus, hernia, varicocele. Evaluation and surgical management of kidney stone disease, surgical management of tumors and malignancy of the kidney, bladder, and testes. Evaluation and management of urologic tract problems identified before birth, and urinary problems associated with neurological conditions such as urinary fever. Urinary incontinence and body dysfunction are extremely common medical conditions among children. Urinary dysfunction, also referred to as body dysfunction, is a general term to describe abnormalities in either the filling and or emptying of the bladder. It is a common problem in children and constitutes up to 40% of pediatric cases. Bladder function normally evolves from the voluntary bladder and clean urinary function.
Why is everybody silent? Dr. Gur?
Here.
Yeah.
Thank you very much for the lecture. Anyone has question? Dr. Sunil, you coming from the pathology world. You came across this kind of
Yeah, I mean, we find a lot of cases of bedwetting as such, but the most commonest what we find is like the control of, I mean, how are you able to control the bladder this thing hyperactivity and or hypoactivity? Any I mean any other than botulinum toxin which you inject or doing anything other than non-invasive kind of a technique which you have used and which have showed result? Hello?
Is with us?
No, I think he's not with us.
Not with us? Huh?
No, I don't think so.